Good afternoon, everyone, and welcome you all to our today's session on health insurance information platform, which we call HIIP. So we will be getting details around the e-objects, those we have designed for the provider payer space in healthcare. As we all know, the insurance sector is booming these days, and because of COVID, it has taken a different height altogether. So I welcome Supriya today to walk us through this session, and any question and any answer, please feel free to write it in the comment section, or we'll take it once the session is over and we will be there on the meet to take it any discussion. Thanks everyone. Over to you, Supriya.
All right. Thank you, Komal. Hi, everybody. My name is Supriya Kotra Prabhakar, and I will be talking to you about the health insurance information platform today. By definition, the health insurance information platform is a technology solution that can be used to manage various aspects of the health insurance process. Thanks. To understand the health insurance information platform, so let's take a look at the insurance sector itself, the health insurance sector in India. The health insurance coverage is quite low in India compared to other countries. The private health insurance covers about 3% of the Indian population, and the public health insurance covers about 10 to 17%. Because the insurance coverage is so low, there is a very high out of pocket expenditure, which is about 80 to 80% and above. So with the launch of the central government's PMJ program, which is also called the Ayushman Bharat, the insurance coverage is set to go up to about 40 to 50% of the Indian population and is likely to cover up to 500 million people. So, looking at the insurance providers, there are about 17 plus private insurance companies that also provide health insurance, and there are about 4 public sector insurance companies that provide health insurance. So, with PMJ, there is a big push to ensure that there is a larger population that comes under the coverage of health insurance. And this is happening because PMJ is set to cover both public and private hospitals. So, with a larger population coming under the health cover, what's going to happen is that the volume of health insurance claim is going to go up. Traditionally, what's been happening with limited number of claims is that all of this has been handled manually. But with the insurance coverage going up to 40 to 50%, the claims are going to go up exponentially, and it is expected that this cannot be handled manually. So there is also going to be a demand for these claims to be in an electronic format, and PMJ also demands that the claims are in a certain standardized format when they are submitted. Also, there are health information standards that have been laid out in the National Digital Health Blueprint laid out by the government, which also defines how health insurance claims should be shared between the payer and provider. So there's a clear financial lever in this digital health transformation. Next slide, please. Okay. So this slide talks about the Indian public health insurance journey that has taken place over the years. So starting with the ESI schemes and the CGHS schemes that were introduced way back in 1940s and 50s, there were about 75 million people that were covered under multiple of these schemes. Going further, there were multiple other state and centrally run programs that were launched, covering about 300 million people. Now, with the introduction of PMJ in 2018, the health insurance coverage now is going to increase to about 500 million people. So, with the health insurance increasing to such a large extent, electronic format of claims is going to be the need of the hour. Next slide, please. Okay. So this is the depiction of all the various stages and processes involved in a health insurance solution. And the various blocks that are seen here in different colors are showing the levels of technology maturity of these processes. For example, the ones in blue mean that there is some sort of a technology solution that's present to perform these processes. The ones are in white are completely manual at the moment. The ones in red are processes that are absent in India. Ones in purple are a hybrid, hybrid status, which means that some exist manually and some have some sort of a system in place. The ones in orange are the integration points. That means that there are multiple of these systems that are available and they need to be interconnected so that they can serve the purpose. All right. So the parts of the solution that actually have some sort of a technology platform or a technology solution are those that have some sort of an AI engine that can translate handwritten claims to digital format. There are certain features that are being developed by few of the insurance companies currently, which allow correct picking up of ICD codes based on the claim information that is provided. But accuracy of these algorithms is currently about 80%, which is not a very high level of accuracy to have when it comes to health claims. So let's take a look at each of these processes and the various stages in the insurance processing. So, coming to the beneficiary management system, this is the first step where the identification of the beneficiary happens, which is also identifying the right population that suits a specific insurance plan or a program. So, in case of a public health insurance plan, example PMJ, this was done using the census data, and a certain set of population was selected based on the eligibility criteria that was set by the government for PMJ. The beneficiaries were then sent out eligibility letters, which were called the PM letters, and all the recipients were asked to visit the nearest CHC or a secondary care hospital to get themselves enrolled after a verification process. They were also given something called a golden card, which allowed them to get identified themselves as being eligible for the scheme. So basically, an identification process is done where the right kind of population is selected for the specific policy that is being formulated. There is also the beneficiary information system, which is nothing but a beneficiary database. This contains information about the beneficiary, including his demographic details, identification details, verification information, the coverage, other insurances that he has, his inclusion, exclusions. So, a lot of information about the beneficiary is stored, and all of this is tied to one particular ID, which is the beneficiary ID, so that it allows the beneficiary to be uniquely identified across the beneficiary management system. Now, moving on to the policy management, just a few of these processes are manual at the moment, and two of them don't exist in India currently: actuarial science and policy redesign. Policy definition is basically a point where a specific policy is defined for a particular target audience based on the disease burden of that particular population, age or comorbidities, or etc. Say, for example, in case there is a high disease burden of diabetes, there is going to be a diabetes plan that can be rolled out by a health insurance provider. So this is in case of a private health insurance. But in case of public health insurance schemes, there are larger programs like PMJ, which intends to cover multiple levels of care and all specialties of care without having any sort of inclusions or exclusions of specific medical conditions, etc. Coming to the price and risk analysis, this is nothing but a process where there's a mechanism that's designed to define the premium payments to be made for a particular policy. So how does a health insurance provider decide what is the premium amount that one should pay to avail a specific plan? This is what the pricing and the risk analysis is where this is decided. So basically, we all know that how health insurance works. It's completely based on risk pooling. So there is a large population that is covered under a specific policy, and it's expected that about 90% of this population is going to stay healthy and would not require or seek healthcare services. But 10% of this population could end up needing healthcare services and would end up making a health insurance claim at some point in time. And this 90% of the population availing the policy would end up paying for the 10% of the health claims. So, this is what happens in case of a health insurance, private health insurance, where a premium amount is defined based on all of these parameters, and the health insurance provider would specify that as the premium amount, and that would need to be paid by the beneficiary at a particular frequency, annually or whatever is set by the provider, and then the beneficiary starts reaping the benefits of the insurance plan. But in case of a public health insurance, there is no premium amount that is required to be paid, because this is generally funded by the government, which is the health insurance provider. It's either the state or a central run scheme. So based on that, that particular entity would fund it. So moving on to provider management, this is basically a system used to manage network of hospitals that are part of the empanelment for a particular health insurance provider. The details of facilities that are available within the hospitals is stored, which would be used to verify when a claim comes through that particular hospital. This is also a place where specific contract related information between a payer and provider is defined and stored. Say, for example, the pricing for specific services for certain kinds of hospitals would be different, or that would be defined in a contract between the payer and a provider. And whenever a patient takes service from that particular hospital using the insurance plan, which has a specific tie-up with that provider, the agreed upon rates would be charged for the patient. So in order to have all of this, all tariff related negotiations are done between the payer and provider, and these predefined contracts and tariffs are created, and they are made available in the provider management system so that they can be used as and when claims come through. Moving on to claims management. This is basically a manual process at the moment, as we discussed previously. And this is a process where claim is submitted and the claim is basically validated by a team of doctors and the admin team based on the information that's provided. The doctors, the validation team would go through each and every line that's present in the claim, along the kind of information that would be present is the discharge summary, all the information related to the patient's visit to the hospital. All of this information would be present, and based on that, a claim would be adjudicated, saying that it is denied or passed. Fraud management is completely manual at the moment and is basically to ensure that there is no fraudulent activities that are happening from any kind of stakeholders within the health insurance solution. So fraud management system would have basically some sort of an fraud alert mechanism, which would trigger alerts whenever there are claims that require some sort of a manual checking or an intervention. Then fund management is basically a way to keep tabs on where the health fund is being utilized. So in case of the public health insurance, this is being done by the National Health Authority. In case of Ayushman Bharat, NHA was actually brought in to control and monitor where the health fund is actually getting utilized. So in case of Ayushman Bharat, what has happened is that in order to implement this central government program, the states have had to integrate it with their current schemes or programs. So in order to provide the service, the states that have implemented Ayushman Bharat, they would the center would fund about say 60% or 70% of the claim, and of the amount, and the rest of the amount, either 40 or 30% of the rest of the amount, is funded by the state's health fund. So that way they work in tandem with each other, and thus Ayushman Bharat becomes the primary health insurance provider, and the state's insurance provider, which happens to be the secondary insurance provider. Moving on to compliance and reporting. The IRDA expects that the details of the claim data be sent to them in a prescribed format, and this needs to be sent to them monthly to the Insurance Bureau. And this is currently being done by just the private health insurance providers, and there's nothing much being done with regards to the public health insurance schemes. Next slide, please. Okay. So, given all of this, and given the fact that the claims are going to be no longer handled manually, the need for electronic claims is very well made. The National Health Authority brought in the concept of a common claims platform, which is basically a technology solution that is used to solve the problem of interoperability between provider and provider and payer. So, this is also when the concept of e-objects was introduced in the book called The Health Systems for New India, which was released by Niti Aayog in 2019. And chapter 5 was written by Dr. Pankaj Gupta and Professor Dennis Traveler, describing the concept of e-objects that can be used to solve the problem of interoperability. The e-objects were later detailed out by Access Health, and we will shortly take you, we can take a look at what the e-objects are and how they can really help in the entire process of interoperability and in the health claims processing. So, e-objects are basically electronic packets of data that are machine readable and have minimum amount of information required for a system to make a specific decision. So in case of an e-claim object, the decision that would be made is to pass or fail a claim based on the information that is provided. There are different types of e-objects that have been defined for the purpose of health claims processing. Some of them are on the provider side, some of them are on the payer side, in order to facilitate different aspects of the claim, ranging from IPD to OPD. So in case of the IPD claims, that is whenever a patient is availing inpatient services, there are various steps, various aspects that happen, various processes that happen during the inpatient visit. So based on that, there are 6 objects that were defined: the coverage eligibility request and response object, pre-authorization object, request and response, claim request and response. And in case of OPD claims, which is being done by very few insurance providers at the moment, in case of that is for the outpatient claims, e-prescription and e-encounter notes, and e-referral. And for provider payments, the e-objects required to process payments between the provider and payer are a payment notice object, payment reconciliation object. So most of these e-objects are currently being implemented, but in a few years we would see multiple implementations of these, demonstrating a good fair amount of interoperability. So moving on to the next slide. Okay. The e-objects were adopted by the National Health Authority and were published in the IRDA NHA Joint Working Group report on health insurance claim management. So what an e-object does with respect to the health claims platform is that it carries a minimum amount of information that is machine readable, that can be used by a health claims platform, which basically acts as a router to send information to the required health insurance provider and send information back to the healthcare provider. So basically, what the health claim platform is doing here is act as a postman between the payer and a provider. So when an e-object is generated by a healthcare provider, it is sent to the health claims platform. The health claim platform would route it to the right insurance provider, and the insurance provider receives this packet of information, processes this because this is machine readable. The health insurance provider can then pass or fail the claim based on whatever information that is provided within the e-object. So, traditionally, what would have happened is that when an inpatient claim is to be sent to a particular health insurance provider, it has to go through a hospital. It has to go through the hospital's insurance desk. Say, for example, in case of an inpatient scenario, a patient gets admitted into a hospital. The insurance desk from that particular hospital would collect all the patient's information and send it to the his or her insurance provider with all the information like his discharge summary, all the doctor's notes, the test results, etc., to the specific insurance provider by way of paper or by uploading it onto some sort of solution, an online solution, or um, some sort of a technology solution there. And then the health insurance provider would take a look at all of this, provide it to the validation team, where they would look at all the details provided as part of the claim, validate that, and then would again come back to the provider asking for any follow-up queries. And then this would take a lot of time, going back and forth, and finally a decision is made based on the adjudication of the claim. So all of this is done with a lot of uh, time and effort that is taken up. So, as we spoke about the claims going up due to the coverage, as the health insurance coverage increases, these claims are going to go up, and it's going to be humanly impossible to handle the volume of these claims manually. So the health claims platform is going to be a common platform that will allow different health insurance providers to get plugged into the system as on one side and the hospitals on the other side, so that this information exchange can be made as seamless as possible. So that is the whole idea behind introducing the e-objects and the health claims platform, so that there can be a seamless transfer or exchange of information between the payer and provider. So I just want to take a pause here and uh, check if Dr. Pankaj would like to add a point or two here.
Thanks, Supriya. I think you've covered pretty much everything. The only thing is that, health claim platform and together with the e-claim object becomes a financial lever for the change. So we always talk about different levers of change for adoption of digital health and everything. So this one is the financial lever because it'll sort of transform not only the health insurance sector but also transform the provider sector. What happens is the health insurance is crossing the 53% mark in India, and with Ayushman Bharat coming in and all the consolidation happening in health insurance, so it becomes a formidable force to sort of bring in standards, and not only just standards because they want to, but they have to, because so many claims cannot be handled by humans. It will have to be going digital, and if it has to go digital, they have to bring in standards because it has to become machine readable. If it has to become machine readable, then the providers will have to provide all the e-objects in the standard format, the e-claim object in the standard format, and that is why this becomes a financial lever. And we've done a lot of research in the background, gone to a lot of CXOs of hospitals, provider organizations, and all of them say that if the turnaround time for the payments can be reduced because of it going machine readable, then that is something that they're definitely willing to sort of support. Currently, mostly the claims are stuck anything between 20 days to 20 months. Now, if that can be reduced to a couple of days, then that's a very big change, and the provider sector is willing to support this big change. So this is not just the health insurance that is sort of changing, But because of the financial lever that the health insurance brings to the table, the provider sector will also change. So that is what I wanted to highlight. In addition to what Supriya said, back to Supriya.
Okay, yeah, thank you so much, Dr. Pankaj. Okay, can we move on to the next slide, please? Okay. So we've spoken a lot about e-objects and the concept of e-objects. So let's take a look at what the e-objects actually look like. So by definition, an electronic claim object, I'm trying to define an electronic claim object here, are electronic packets of data which capture minimum amount of required information essential for processing a claim transaction submitted or requested by a payer or a provider. All right. So but why do we require an e-claim object in the first place? When the IRDA has already prescribed a standardized format for claims to be sent in, why would we still require an e-claim object? So when you take a look at the IRDA's format, which is present on the slide at the moment, there is a form that has been standardized in terms of what kind of inputs it can receive. But what it does not have is the standard value set, and it's not machine readable. Of course, there can be OCR readers that can be used to read and digitize handwritten claims, but there are cases where data is not validated. Say, for example, a date field could be misinterpreted, a DDMMYY could be an MMDDYY. So, data is not the same when it is not coming from a standardized value set. So, what an e-object would do is that it expects a format that requires standard value sets. By value sets, what we mean is that, say, if you've taken a look at any of the online forms, and when you start filling in these online forms, you might have come across lots of drop-down menus, right? So what you're actually inputting is actually coming in from those menus, and these are subsets of values from the value sets. So this ensures that whatever data that you're putting into the system is already clean data and is validated information that is going in. So when a receiver receives this packet of information, he already knows that the information is valid, and all that he needs to do is, and this needs to just get processed, which is also why it's completely machine readable, and it's interoperable, which means that any system that has a specific software solution, say for example, hospital A has solution A and hospital B has another solution B. They don't need to have the same solution in order to exchange data between each other. They can continue to keep their own solution and work with their solution, but use the e-object format to exchange information between each other. So this would allow for interoperability between either provider solutions or even payer solutions. So here is a small depiction of how an e-object would look like. You can imagine this to be an envelope of information where it has a to and from address, which says where the information is going to and who it's intended for. For example, if it's coming from a particular hospital, it needs to say where it's going to, that is, to which insurance provider it's intended to, and all these identifiers like the hospital ID, the insurance ID, the beneficiary ID, the patient ID, all of these identification information is sent in the header, which would ideally be sitting in one line in the header portion of the e-object. And the rest of the information that is available in the object would sit in the body of the object, which would contain the rest of the information pertaining to the policy. That is the policy, the diagnosis details of a particular encounter, all the information pertaining to including the discharge summary, the diagnostic tests that were done, the advice that was given by the doctor, all the clinical information that is required for one to understand what is exactly done during this particular encounter, the package details, and the rest of the information that is required to be part of the claim. So the header information contains all the identifiers, and the rest of the patient information and patient-specific encounter information comes into the body of the e-object. So when an e-object is received, It has all the required information, and this would again be minimum amount of information that would be required for a machine to read, process, and decide on the adjudication whether the system is going to pass this claim or reject the claim. So by sharing and exchanging this information electronically by way of e-object would smoothen the process and would make it quicker for claims processing to happen so that the adjudication process becomes faster. So that is the whole intent of bringing in the concept of e-objects. Can we move to the next slide, please? All right. So let's take a deeper look at the structure of the e-object. There are multiple types of e-objects that can be sent out on specific events. Say, for example, I'm taking an example of the payer e-objects here. Say when a patient gets admitted for a treatment, the hospital's insurance desk does an eligibility check to understand if the patient is eligible for a certain package or not, whether he has the eligibility as part of the insurance package he's coming with to go through a particular treatment or not. So an eligibility check e-object can be generated by a hospital's information system where information about the health insurance plan, the policy details of the patient that he came with, his condition, and all of this information is sent using the e-eligibility check object as part of the checking process through the health claims platform. And when the payer receives this object, he is going to be able to process this, verify this request, and send a response back to the provider saying whether the patient is eligible or not based on the plan and the criteria. So this entire process is done without any kind of human intervention, and the information captured or needs to be just put in the form of an e-object and is to be shared between two entities. So once this eligibility check is done, what would happen is that the hospital would then send information regarding a pre-authorization request, asking the insurance provider to pre-approve a certain amount of money so that the procedure could be started or the treatment could be started. So in order to provide a pre-authorization request, all the information regarding the doctor's advice as to why the patient needs to go through a particular treatment or a surgery or whatever is required is sent along with the details of the patient. And the hospital would come up with its estimate based on what the treatment would cost. And all of this information goes in as part of the pre-authorization request, asking for the provider to approve a certain amount even before the treatment is started or administered. So traditionally what happens is that the pre-authorization request is made using a paper format, and all of this information goes to the insurance, and it would take a lot of time, and the pre-auth comes back from the provider saying about, okay, I would fund you about 80% or 90% or something like that. So once this pre-authorization amount is received, then the patient can be, so it gives the hospital a kind of a go-ahead to take in the patient for further treatment. So following this, what would happen is the patient is admitted, the treatment is done, and the final bill is generated. And the hospital would now send the final bill with all the details, including the discharge summary, which talks about all the tests that were done, the reasons why certain things were done, certain procedures were done, and all the treatment that was given, and all this information is required for the insurance provider to decide on the final decision of the claim. The hospital then awaits information response from the insurance provider for the final amount, and once this is done, a payment notice is sent to the provider. And further, if there are any additional payments that need to be made, those adjustments can be made using the payment reconciliation, which is done using the payment reconciliation e-object. So this kind of structures the different steps that are required, that are entailed in a particular inpatient procedure when a patient gets admitted into a hospital and all of the insurance processes that are involved, there are e-objects, there are objects that will get generated at specific points in time for specific events. So coming to the structure of the e-object, the e-object, the structure is laid out in such a way that the header contains all the unique identification details of all the parties involved in this transaction and the routing information required for the health claims platform. So this information is passed to the health claims platform, which reads only the header part and ensures that the right information is going to the right recipient. And the detailed body, which contains all the other information, is not read by the health claims platform, but it is sent to the right recipient, which is the health insurance provider or the health care provider, and that system would be able to read this information, which generally contains standard minimum required data elements required by that payer or for auto adjudication of the claim. So this is basically the structure of the e-object. Here, in case of this, we are discussing the e-claim object. So in order to have these identifiers, can we move on to the next slide, please? Yeah. So in order to have these identifiers, there needs to be a single source of truth, which would mean that these identifiers are unique across a particular system. So as we speak, the national registries for doctors, payers, providers, facilities, and beneficiary is being designed in by both jointly by the National Health Authority and the National Digital Health Mission. So these registries would ensure that a doctor is uniquely identified across the entire system. You have a facility ID associated with hospitals, so that a specific hospital is identified uniquely across the entire system. You have the beneficiary ID, which provides a health ID to the patient, and similarly for the payer. So all this unique information ensures that there is no confusion regarding identifying the patient through this entire process, so that this becomes completely managed by a technology solution or a software solution to process the claim. Okay. So apart from that, the other information that is present as part of the claim object is that you have the clinical information, clinical summary information, which has all the details regarding the episode, whatever tests were done, all the procedures that were done, all the treatment that was given, all of this information that would be required for a clinical team to evaluate and check if the right things were done and no fraudulent expenses were raised or any of those kind of issues are taken care of. So clinical information is provided, and that would sit in the body of the e-object. And then in case of an e-claim object where the final bill or the bill information is available, the bill summary is attached. And in case of pre-authorization, pre-auth details would be mentioned in the body of the e-object. Final treatment details and the cost, and all of these would be present. The disclaimer and digital signatures would ensure that the right information is being sent, and this was an authentic treatment that was actually done by the hospital. So this is basically how the e-objects have been defined and how they really cater to the need of the hour at the when the health insurance claims are going to go up. This would be useful in ensuring that the turnaround time is faster, and there isn't too much of an effort, or the claims are not getting stuck for a very long time, and the both the payer and provider are they benefit out of this entire process, and at the end of it the patient is going to reap benefits with the claims taking much lesser time as compared to the manual handling of claims. So, can we move to the next slide, please? Okay, so we're coming back to the slide just to let you know that now I think you would have had a fair idea to understand how the e-claim object works to operate between the payer and provider, and using the health claims platform, which works as a router or a postman to direct this information between these two entities, and to ensure that the right amount, the right recipient gets the information, and the right actions are taken, and then the provider and the payer are both benefited out of the entire process. So I would take a pause here and check if Dr. Pankaj would like to add anything at the end of this slide.
Thank you, Supriya. Um, the only thing I want to add is that in an e-claim object, you have parts of the e-discharge summary already, and you also have parts of the package and billing, so that uh, the payer doesn't have to go and open any other document. So you have everything in the e-claim object to make the decision about whether to pay or not, how much to pay, and it is approved, or they are holding it back. Whatever decision they want to do, they can make from the e-claim object itself. However, there is an option of going and opening the additional e-object, which is the e-discharge summary, and then that is something that is available in addition to the e-claim object. Of course, there is a privacy and security model that there has to go through, because of the privacy concerns of the data that may be there. But leaving that aside for now, the option is there for the payer to go to in addition to the e-claim object, go to the e-discharge summary object and pick up all the details. So in the e-discharge summary, you will have all the the lab information, and all the radiology information and things like that. In addition to that, if at all the payer needs to go and open a discharge summary, the actual discharge summary, uh, those can be there as an attachment initially, but we don't see the need of that going forward. Over a period of time, the e-claim object itself will be self-sufficient to be able to make the decisions, and e-discharge summary will be the maximum that will be required in addition to the e-claim object. And going to the physical discharge summary or the detailed discharge summary in a PDF format or whatever is going to be history over time. So, I will say history from a payer perspective. The providers will still have it, but it is also a possibility that the provider systems will generate the discharge summary in the e-discharge summary object, and they will also store it as it is. They really don't have to generate the reams and reams of documents and store it over time. These e-objects are very easy to store. They have a very small footprint. So because they are converted into JSON technology, which has a very small footprint and very easy to manage. Why I am stressing on this is because ultimately, when you have to do, when lots of data gets accumulated, you will have to build a longitudinal record of the patient. You will have to sort of figure out what happened to the patient from a payer perspective as well as from the provider perspective. And then you need a document registry. For a document registry, all the e-objects become the tags from which you can point to the detailed document wherever it is residing. I think I've gone a little further than what was intended, but my point was that I wanted to tell you how the e object is so flexible in terms of the payer as well as the provider, and it will become the pointer going forward for a detailed information that may be residing in the respective systems. Back to you, Supriya.
Thank you, Dr. Pankaj. That was actually helpful. So I think I'll take a stop here at what we've covered today, and in the next session we'll be getting deeper into the health claims platform, and we'll try to understand more steps and processes involved in that. So yes, thank you very much.
Okay, thank you, Supriya. Dr. Pankaj and Supriya, I would request you to join the meet link. We can have an open discussion and share our experience around the claims and payer site. Thank you. We can close the screen yard now.
Sure. Thank you.
Thank you.